There's a lot of efforts ongoing with developing immunotherapies in acute myeloid leukemia, which makes sense because these have dramatically improved responses, durability, and outcomes in other heme malignancies like acute lymphoblastic leukemia, myeloma, CLL, and others. So we have not had, unfortunately, the level of success so far, not for a lack of efforts. There have been various immune checkpoints, PD-1, CTLA-4, as well as more recently, innate immune system activating agents such as macrophage therapies, CD47, SERP alpha, that have been evaluated. And due to various reasons, either toxicity or lack of efficacy, these have not yet led to major approvals. I personally think the antibody drug conjugates are really going to be the way to go for drug development for the next 5 to 7 years in acute myeloid leukemia. We already have one of these, a CD33 antibody drug conjugate called gemtuzumab ozogamicin approved. This drug is moderate in efficacy and does have some complications like VOD, but it still has efficacy that is good in patients with core binding factor, acute promyelocytic leukemia, and certain other subsets. And I think we have now the technology for much better linker, much better biological toxins, which are not using bacterial components, as well as better ways to deliver these antibodies. And so there's a gamut of these that is coming into the play with CD123 as one of the main targets, various ADCs, including the pivekimab IMGN 632 in advanced development in both acute myeloid leukemia and blastic plasmacytic dendritic neoplasm. Hopefully, we will see potential approvals for this in the near future. And even beyond that, there are numerous new ADCs targeting CD123 coming from AstraZeneca, Vincerex, other groups, as well as efforts to retarget CD33 with better toxins, linkers, and products. So I think this is going to be, for the next 5 years, the way of development. Cell therapies, both CAR T, NK, are also in early development, but we have had issues such as active monocyte activation syndrome, CRS, HLH, prolonged cytopenia. So we're looking at genetic manipulations as well as other modifications for these CARs to mitigate these side effects and have more on tumor activity rather than on target off tumor activity. And it will take a few years, but with the current science, technology, as well as ability to genetically modify and change these CAR Ts, I think we are going to see some of these in the AML space succeeding in the next few years. So it's a very exciting area, but we still have a lot of work to do to catch up with the efficacy and outcomes that are being seen with our colleagues in other lymphoid and myeloma diseases.